my name is Kira Reinhold. I'm a fourth year medical student at New York Medical College. And tonight we're going to talk about harm reduction and substance abuse. So this is a little bit different from maybe some of the other virtual shadowing sessions that you've joined. Instead of talking about a specific condition or diagnosis, this is more of a strategy that's used specifically in regards to treating substance abuse. But as we're going to talk about, it's kind of a philosophy that we can apply to many parts of our lives and specifically our medical careers. Um, okay, so a little bit about me. I went to Yeshiva University. I graduated 2019. I majored in English. Like I said, I'm currently at New York Medical College. I'm an M4, so I'm a fourth year. I'm applying to residency in 2 weeks. I'll be applying to psychiatry residency. Um, and I joined Motivate MD in 2022, so it's been about 2.5 years. Then on the right here is a picture of me with some of my classmates. That was the last day of our surgery rotation. It's me in the green sweater. So for the outline today, we're going to have a short case to kind of introduce the topic. Then we're going to talk about what is substance use disorder, what is harm reduction. Remember to fill out the SOAP note. If I ask questions, feel free to unmute yourself or just drop an answer in the chat. Okay, so make sure that you have your form in front of you. All right, let's start with the case. So a 21-year-old man is brought in by his friend to the emergency room. His friend says that they were at a party when the friend disappeared for a bit. When his friend went looking for him, so this is, I guess, this is the patient's friend, he found the patient unresponsive and called 911. Prior to that, the patient had been acting normally. According to his friend, this is the patient, it's a little bit confusing. He has no medical conditions, but he had knee surgery 1 year ago. There was alcohol at the party, but his friend is not sure if the patient drank. Okay, so kind of to summarize, we have a 21-year-old man. We don't really know any of his medical history because he's brought in by his friend. The friend seems a little bit frazzled. They were at a party, and the friend is unresponsive. That's kind of the major takeaway here. So it's kind of an emergency situation. We have an unresponsive patient. There might be some alcohol involved. There might be something else involved. We're not really sure. So just drop in the chat looking at this, like what are some things that comes to mind, whether it's a diagnosis or a test you want to do or a question you might want to ask the patient's friend? I'll start. I kind of want to assess what it means if the patient's unresponsive. I might want to check for breathing, check for a pulse, come up to an EKG machine, see if they have a rhythm, like if they're in cardiac arrest. So the first thing that comes to my mind here is they're at a party, right? Maybe alcohol is involved. But other things that happen at a party is drugs and substance use. So when you have a patient who's unresponsive, who might have used drugs, it's really important to think, okay, well, what do we know about substances and how can we kind of quickly reverse the effect of a substance? And we'll talk about that in a few slides of what I'm getting at. So looking at his vitals, his heart rate is 57. BP is 105/70, so slightly low. Respiratory rate is 10. Temperature is 99.1. So kind of what jumps out to me here. So remember, heart rate should be between 60 and 100. So his heart rate is a little bit low, minimally low. Blood pressure is average about 120/80. So his is like slightly low. But anyone know what the respiratory rate should be ideally in a patient? It's kind of a hard one because I didn't really learn about respiratory rate till med school. But it should be higher than 10. I'll leave it at that. Somewhere about maybe between like 13 and 15. So the fact that his respiratory rate is 10, it's not crazy low. Like I'm not really I'm concerned, but it's not like it's 5, but it's still very low. So I'm concerned. And his temperature is 99.1, so very slightly elevated, but again, nothing really to be worried about in terms of his temperature. Like I don't think he's, in septic shock or anything like that. That would, come with a much higher fever. So in terms of his physical exam, our general impression of the patient is that he's unconscious. And something I like to drive home whenever I'm teaching is that, the first thing you want to do when you're assessing a patient in a physical exam, and then when you present them later on to a resident or an attending, is what was the patient's general appearance? So that's really important for kids. because, kids act really sick, and that's kind of how you know if there's something going on with a kid. You know, is the patient in distress? The patient acting normal, acting fine? It's always something you want to get a sense of. You don't really think about it all the time when you think about a physical exam, but just that's really important because it can give you a good clue into what's going on. So our patient is unconscious. That's, kind of the general um, impression of him. In terms of his head, eyes, ears, neck, and throat exam, his head is atraumatic, normal cephalic, and pinpoint pupils. So that will be important. But that essentially means that his pupils are small. Cardiovascular, he has a regular rate and rhythm. In terms of his respiratory exam, he's shallow breathing, but he has normal breath sounds. GI exam is normal and extremities are normal. So I will say, if any of you might have worked as an EMT before or in an emergency room, the patient is unconscious, so your physical exam is kind of going to be a little bit rudimentary, kind of just to assess the important things. So I don't have everything here, but this is kind of like a general impression of the patient. So what are some of the important things that stick out to you guys in the vitals or in the physical exam with this patient? So what sticks out to me is, of course, the fact that he's unconscious. And the most important things I would say are the respiratory rate, the pinpoint pupils, the shallow breathing. So this is a very specific patient presentation, and we'll find out why in the next slide. Okay, so let's move on. Let's look at his labs. His electrolytes are all pretty good, so I won't go into them. His HCO3, I'd say like everything's grossly normal at this point. Talk about why I mentioned the HCO3 a little bit later. But importantly, you get a urine tox. I'm not sure if that's the first thing we would get right now because the patient's unconscious, but let's say at some point in his hospital stay, we found out that he's positive for opiates. That's kind of what I was getting at with all of this. I'm not really going to focus on the case so much because I want to focus more on the topic, which is harm reduction, which is more about the treatment. But essentially going back, we have a picture of a patient who's overdosed on opiates. So he was at a party. Obviously an overdose can happen anywhere, but something you'll get commonly on exams in medical school is, a young patient at a party or hanging out with friends or something like that. The patient's unresponsive. I also threw in the knee surgery here just because they might give you a clue about, the patient might have had some surgery where they might have been prescribed like pain medication, and that can kind of, maybe have led to substance use issues, but that's kind of a stretch. That was just a little thing through in there. But the important parts is that, he's unresponsive at this party, used substance. And then in the physical exam, the respiratory rate. So the big reason why opioid overdoses are so dangerous is because opioids cause respiratory depression, meaning they suppress the brain's sort of respiratory drive. So, normally when we don't think about it, we're breathing because our brain is telling us, when to breathe and how often to breathe. Because opioids kind of depress that response, a patient's going to be breathing less. And what happens when they breathe less is they take in less oxygen. So that's why, opioid overdoses are really dangerous because then what happens is, the patient doesn't have enough oxygen, kind of to put it simply, they go into, respiratory acidosis, I think. Yeah. And that can kind of have lethal effects. So his respiratory rate is low. He has shallow breathing. And the other important part here is pinpoint pupils. So often patients with there are certain substances that will cause changes in the pupillary size. And specifically for opiates, they cause constriction of the pupils. So they may call that pinpoint pupils, but the pupils will just seem really small. Okay. So very briefly, just to get into like some emergency and trauma medicine here. When you have a patient who is sort of unconscious or unresponsive or has just gone through like trauma, not like an emotional trauma. I'm going to psychiatry, so that's kind of my first thought, but like a physical trauma, coming into the emergency room is ABC, and then I added N because that's kind of relevant to our case. Does anyone know what ABC stands for in the context of emergency medicine? You want to take a stab? So the A is airway, B is breathing, and C is circulation. So And then the N, which we'll get into later, is Narcan or naloxone, which is, what we're going to use to treat the overdose. But ABC is kind of covering up the N is what you really need to know for trauma response. So airway. So the first thing you want to say is, okay, is the patient's airway open? Is air actually able to get from the atmosphere through their airway into their lungs? So if a patient, let's say, had a trauma, let's say they experienced an injury to the neck, or they're having an anaphylactic reaction. So maybe, their airway is swollen and inflamed and air can't physically get through. Maybe they're a newborn and they have some sort of congenital anomaly, which prevents air from getting into the lungs. But basically the first thing is, okay, can the air actually get into their lungs? So we want to kind of assess that. And then if there is no airway, the answer to that is, okay, we need to intubate the patient, which is we kind of stick a tube down the throat, which keeps the airway patent or open and allows, you hook up the oxygen to the tube and it allows like direct air entry into the lungs from the tube. The next thing is breathing. So, okay, maybe the patient has a patent airway, right? So our patient, right? He didn't have any trauma. He's not having an allergic reaction. His airway is open, it's patent. But is he breathing? So that's kind of the next thing to establish. If they're not breathing, we need to physically back them or physically like manually provide them with oxygen. And even if they're not breathing, if their breathing is shallow, we're concerned that even though the air can get into their lungs, that they're not breathing enough oxygen. Then you might also provide air, oxygen to them. The last thing is circulation. So I guess to put it simply, how is their blood? Is it circulating through the body? Are they losing a lot of blood? Is there enough blood? Is their blood, maybe they're septic, and so they're unresponsive because there's an infection in their blood. So kind of stabilizing all these three things are the first things that you want to do when you have a patient who's unconscious or in an emergency situation like this. In our patient, his airway's fine, his airway's patent, but the issue here is more his breathing, because he is having respiratory depression due to the opioid overdose. And his circulation is fine. His blood pressure was okay, his pulse was okay, so right now we're not really concerned about it. And so the last thing, the N here, which is not standard protocol in any emergency, but the most important thing to do right now is naloxone. So what is naloxone? I guess we'll talk about that later, but essentially naloxone is a opioid antagonist, which means it blocks opioid receptors, and it's sort of an immediate reversal of opioid overdose. So when you have a patient who you suspect has an opioid overdose, it's kind of like with an EpiPen. You suspect someone's having an allergic reaction, you might just stab them with the EpiPen. Similar to naloxone, you suspect a patient's having an opioid overdose, you can kind of provide them with naloxone in this emergency situation because it's not like a dangerous medication. It's like more helpful. The risk is greater if you don't use it and they are overdosing than if you do use it and they're not overdosing. We'll talk about that more later. But just a quick assessment and plan for this. 21-year-old male, unknown medical history, brought in by ambulance after being found unconscious at a party. On exam, he was found to have decreased respiratory rate and pinpoint pupils. Detox was positive for opiates. He likely overdosed on opioids, leading to respiratory depression, so that's our diagnosis. Plan is administer naloxone, intubate if necessary, patient to ICU and assess for substance use disorder, and then get a more comprehensive history once the patient is more medically stable. Okay, so let's talk about substance abuse disorder because that's kind of really the meat of this presentation. So you might have heard it addiction or substance abuse disorder. The correct medical term is substance use disorder because addiction kind of has a negative connotation. So we're trying to move into a more descriptive term when it comes to the diagnosis. And the most important thing to think about with substance use disorder is that it's a treatable mental disorder. It affects a person's brain and behavior, leading to inability to control their use of substances like legal or illegal drugs, alcohol, or medications. So I think, 50 years ago, and even still today, unfortunately, definitely today, there's still a stigma. But when we call it addiction, it kind of makes it seem like these patients have a lot of control over their actions, it's something that they can easily, they're an addict. So, it's not a disease. There's something wrong with them and there isn't really anything you can do. but we have to really consider that it's really a diagnosis like any other diagnosis. It's something that can be treated. It's something that's not the patient's fault. Especially with addiction, it alters the brain. So patients, especially addicted to opioids, um, their bodies become physically reliant on it. So it's not only a psychiatric condition, or it's not only like an emotional reliance, but it's a physical reliance as well. Um, so some substances that people can become reliant on or opioids, like in our case, alcohol is also a very common, substance and substance use disorder, sedatives. So something like, benzodiazepines, marijuana. So there's kind of discussion right now in the substance use disorder world about whether or not marijuana is an addictive substance. But the consensus is that yes, the patient can very much have substance use disorder, and the substance in question is marijuana. And stimulants, cocaine, crack, methamphetamines, any of these things can constitute substance use disorder. And often it's not just one. Patients might use multiple substances, and um, that could definitely be present in a diagnosis. So why do we care so much? So if you've been paying attention at all in the last 5, 10 years, you know that specifically opioid overdose deaths are a really big problem in this country. You might have watched Dopesick, which was a TV show a few years ago about how big of a problem it is in the country. There's a lot of media out there, a lot of books, because it really is a big problem. And if you look at this figure from the CDC, you can very obviously see that the number of overdose deaths as of 2022 was very rapidly increasing. We'll talk about why that is in the next slide. But it's a really big problem. It's not something that's going away. It's something that's getting worse. And so it's something that really needs to be addressed. And, as we'll talk about later, we might need to sort of change the way we think about substance use disorder in order to better treat it, better prevent it. So this was the question on Instagram to kind of give you a little taste of the session. But why is it that opioid related deaths are increasing? And so if you see here, this green line is synthetic opioids other than methadone. So here you have heroin, natural and semi-synthetic opioids, and methadone. So clearly this green line is really rising above the rest. So in the last, I guess, 10 years, we can say sort of since 2014, the introduction of synthetic opioids like fentanyl, and the fact that a lot of drugs or substances that people might buy might be laced with these synthetic opioids really contribute to the fact that there are more deaths, because often synthetic opioids are much more potent or much more strong, and have a lot stronger effect than heroin or other natural, I guess, or semi-synthetic opioids. And so this is really the problem, the fact that we have these synthetic opioids on the market, and the fact that a lot of other opioids are laced with synthetic opioids, and the fact that they're so much more potent and can easily cause death is really a big problem. So like we said, the increased use of heroin and synthetic opioids is really one of the driving causes of the rising rate of opioid related deaths. There's other reasons too, the fact that they're still prescribed a lot. We talked about how I kind of added in the patient had a knee surgery, and maybe his provider prescribed him Percocet or some other opioid, and often they're needed. Surgeries are really painful, and patients are in a lot of pain. But I think if it kind of becomes the protocol to prescribe opioids for every surgery. I had wisdom teeth surgery. They didn't even ask me if I was in pain. They just wrote me a couple of prescriptions, and one of them was for Percocet. So kind of this overprescribing of opioids is maybe one of the reasons that we have more opioid overdoses, because patient might start off getting prescribed by their provider, and then they become reliant, and then they might sort of look to other sources if they can't get it from their provider anymore. Inadequate regulation is also a reason why opioids might, um, opioid overdose deaths might be increasing. Something I do want to kind of note is that so there were two in the Instagram question, one of the answers was okay, the reason that opioid overdoses are increasing is because of synthetic opioids. And the wrong answer was that there's inadequate criminal consequences. There's no evidence to show, there's no evidence at all to show that, the way to crack down on opioid overdoses is to increase incarceration or increase you know, I guess getting the legal system involved. So that was, I just want to make sure that we know that that's a really wrong answer, because there is no evidence that if we increase criminal sentences or put more people in jail, it's going to solve the problem. That's really not, how to address this issue. Okay, so let's get into what exactly we're talking about today, which is harm reduction. So very literally, harm reduction is reducing harm. The more technical definition is policies, programs, and strategies to reduce negative consequences of behaviors without requiring abstinence. So skipping to the bottom here, I like these two quotes because they kind of really give you a nice idea of what harm reduction is. So let's not even think about drugs right now. Um, let's think about riding a car. No one is saying that people shouldn't ride cars, right? Riding in cars or driving in cars is, necessary for people to get where they need to go. But we know it's a risky activity. People die in car accidents way more than they die in plane crashes. But the answer to that isn't saying, well, don't drive. The answer to that is, okay, well, what can we do to keep people safe while they drive? Let's have people wear seatbelts, airbags, car seats, speed limits. So the idea is we have this activity, whether or not this activity is part of daily life, so driving or going in the sun or, sexual activity or smoking, regardless of whether or not we think people should be doing it, we acknowledge that it's a dangerous or risky activity. But instead of saying, no, don't do this activity, we're saying, okay, how can we safely or more safely do this activity? So with these things, these are more normalized, right? Going in the sun, going in the car, having sex, smoking. So it's easy for people to say, okay, yeah, I understand that we can't stop driving, we can't stop, going in the sun, smoking, a little more iffy. So let's go back to the drug thing though. So this is kind of hard for people to understand, right? Because most people are like, well, no, the answer to stopping people from doing drugs or, reducing deaths from doing drugs is to have people not do drugs, right? Harm reduction is saying, well, no, right? Because we have to be sort of cognizant of reality. We can't tell people, okay, the only way to safely not overdose or not die from using substances is to not do substances. That's one philosophy. But a more really realistic and productive thing to say is, okay, we know that we're not going to get everyone to stop using drugs. It's really difficult. It requires a lot of resources. It's definitely the goal for everyone, but we need to be more realistic. So we're not going to get everyone to be abstinent. So what we can do is acknowledge that there will be slips, minimize the damage, but not demand perfection. So for example, a patient who's an opioid user, we can obviously say that our goal in the long term is to have this patient not use opioids, but right now we understand that they have a disorder, they have substance use disorder. And what can we do to sort of minimize the damage while acknowledging that, yes, they probably will use drugs, but what can we do to sort of minimize the harm from the drug using activity? Since abstinence is the overall goal, but right now we're being more realistic. So that's kind of the overall view of harm reduction, from a larger, more general perspective in terms of like sunscreen and seatbelts and sex education, and then down to the more specific of how it applies to substance abuse. So like I said, these are some examples we use every day of harm reduction. We have a risky activity. We can't stop doing it, or it's not realistic for us to stop doing it. How can we minimize the damage and make it a safer activity? That's kind of the gist. So harmreduction.org is an organization, and it has these 8 or 9 tenets sort of what their goals are as an organization and what the goals are for harm reduction in general. I'm not going to read them all out loud, but skim them now. You can go on the website after. But essentially, what this requires is a really nuanced and mature understanding of drug use. It kind of establishes that people who use drugs aren't bad people. Um, Drug use is something that people often don't have a lot of control over. And how can we help people and treat them with respect and, provide them with help while also understanding that this is a really complex, multifaceted phenomenon. Um, and we're not going to solve the issue. We're not going to get everyone abstinent right now, but what can we kind of do in the meantime to help people stay safe? Um, some more things that I think are really important part of this is that um, it really the aim is sort of to destigmatize drug, I guess, substance people who have substance abuse disorder. Like I said, there's a stigma, and people who have substance use disorder often are um can't what's it called? I can't think of the word. They're discriminated against. There we go. They're treated with a lot of disrespect. So it kind of helps them, put them in better, give them more realistic options for how like you can help them and how they can help themselves. And sort of gives them a voice in creation of these programs because they are the ones who it's going to affect. So I said a lot. I think this website is a really good resource to help you sort of understand the philosophy and the background of harm reduction. All right, so let's talk about actually how harm reduction is actually used in substance abuse. So let's go back to our patient, right? He had overdosed on an opioid and we gave him naloxone. So naloxone or Narcan, which is the brand name, it's an opioid antagonist. So you learn about this in medical school, but there's agonists and antagonists. An agonist is something that, binds to a receptor and activates the receptor in the same way that the original enzyme would. And an antagonist is kind of blocks the receptor in sort of the reverse way so that the original enzyme can't take effect or has kind of a blocking effect, the opposite of what the original enzyme would do. So what naloxone does here, it kind of blocks these opioid receptors so that more opioids can't bind to those receptors. It can decrease or even reverse the symptoms of overdose. So in any patient, like I said, who we suspect has an overdose, we can give them Narcan. And it's really life-saving treatment. It's relatively safe, which is why I said it's better to, you know, give someone Narcan if you have a strong suspicion that they're overdosing. Kind of like an EpiPen. Like an EpiPen's not going to kill you, so it's better to, give the patient the EpiPen than to have them die from the allergic reaction. And it's distributed publicly. It's, something you can easily get through many programs. Just because it's like really it's a lifesaver. It's easily administered. It's like a nasal spray. There's classes all over. We have them at medical school. We have a lot of training sessions about how to use naloxone just because it's really easy to use. It's relatively safe, and it's just like a life-saving drug that can really help people who are going through an overdose. So this kind of touches on kind of one of the tenets of harm reduction in substance abuse, which is using drugs or using substances to treat substance use. So this one makes sense, right? We have a patient in emergency who needs their life saved. They need their opioid receptors blocked so that they can survive. But we'll get into it soon. Like, it's something that people really struggle with harm reduction is why would we use a drug to treat another drug? So this makes sense, right? Because it's kind of like an emergency situation. But I want you to kind of think about that as we move on in the presentation, which is how we get here. So, one of the most, I guess, there's a lot of ways to treat substance use disorder. It's really kind of a multifaceted approach. But we're in medicine, so one of the things we use is medication. We use medication to treat asthma, to treat heart disease, to treat depression. So I don't use medication to treat substance use disorder because it's also a disorder. So that's why we have these medications. Methadone is very commonly used to treat opioid use disorder. It's essentially a long-acting opioid agonist used in both short-term and long-term, so patients could use it for weeks or months or even years sometimes to decrease cravings and withdrawal. So you'll hear of a methadone clinic. Patients will essentially go to this clinic to get their methadone. It isn't something that you would prescribe and the patient would pick up at Walgreens. Because it is an opioid at the end of the day, it's used in a very supervised setting. Patients stay after they take the medication to kind of get supervised. But essentially, this is kind of what people struggle with, right? Because we're using an opioid to treat opioid use disorder, which is kind of like counterintuitive. So I guess start to think about that, right? That's kind of something that people struggle with when it comes to opioid use disorder medication-assisted treatment. And then Suboxone. So Suboxone is buprenorphine and naloxone. So we spoke about naloxone, which is, sorry, let's just say opioid antagonist. Cross that out. So antagonist. And then buprenorphine is a partial opioid agonist and antagonist. So we learned about this in med school, but some drugs have like a partial agonist, partial antagonist effect. So right now, not really important for you to know exactly how these drugs work. What I want to really drive home is like, if you're a patient's family member, you have a family member and they've been struggling with opioid use disorder for a really long time. And you go see this new psychiatrist, and the psychiatrist tells you, we're treating your family member with this medication that we think is really going to help. And you ask, okay, what kind of medication is it? And they say, well, it's an opioid. That can be really confusing for families, right? They have this patient who's been relying on opioids for so long. And then once they hear, like, oh, well, our family member is just going to be treated with the same substance that, has really caused all this harm in their life, it's really hard to swallow. So I think patient education or family education is really kind of key here. Saying like, yeah, I understand why it's really confusing and weird and uncomfortable that we're using a substance or using an opioid to treat opioid use disorder. But specifically with opioid use disorder, I don't know if any of you guys know about withdrawal symptoms. So one of the hardest things about stopping or, opioid use disorder treatment is that opioid withdrawal is really, really, patients feel absolutely awful. Some of the symptoms, they can have really bad GI symptoms, shaking, sweats, like a lot of physical symptoms. A lot of patients describe like feeling like they're going to die. It's like the worst feeling they've ever had. It can't kill you. You can't die from opioid withdrawal. Like, remember that. But it's so awful and uncomfortable. And we don't want anyone to go through that, right? So one of the ways that we prevent that, because let's say a patient is like, okay, I'm going to quit, or I'm not going to do opioids anymore. They stop. They have this awful feeling. They're like, oh my God, my body needs opioids to not feel like this. And they'll start using again. But what we can do as providers is support them through this detoxification and give them methadone or Suboxone to really get rid of these withdrawal symptoms, because that's a really big barrier to people getting treatment. But if we can support them medically, and prevent these withdrawal symptoms, that can really help people get the treatment that they need. So whether it's short term, like getting people through the detox phase, or more long term, these medications, and we'll talk about this soon in terms of the evidence, are really like a very honestly probably one of the best ways to treat opioid use disorder. And we kind of have to think about it like any other disease, right? We're doctors, or you guys are going to be doctors. Use a lot of different things to treat patients, and one of them is medications. So if a patient has depression, give them Lexapro or an SSRI. And a patient has opioid use disorder or substance use disorder, we can give them a medication that will help. So it is important to note that it's not the only thing we're going to treat them with. There's a lot of psychological, emotional, and social support that comes along with medication-assisted treatment. Like I said before, it's not like you're going to prescribe someone a 30-day supply of methadone and they're going to go pick it up from Walgreens and like take it every morning. It's very supervised. It's very often like you have to go to your doctors to get Suboxone, and you have to go to a clinic to get methadone. So it involves a lot of social and medical support along the way. All right. So one way we can use harm reduction in the in the treatment of substance use disorder is medication assisted treatment. Um, and another way we'll talk about now. So anyone know what's going on in this picture? Okay. So this is actually something called a safe injection facility. And essentially, okay, what this is a place that people can go and safely use substances. So this is again, harm reduction is confusing. It's confuses a lot of people. Why would we set up government? Why would we use government funding or, taxpayer money to allow people to do drugs? Um, that's kind of what a gut reaction is for a lot of people. Like, why are we like condoning this activity? Why are we, kind of giving people a space to do something that's so bad or so dangerous? That's what someone might say. Um, so essentially what it is though, it's a place where people can go and to use substances under the supervision of medical professionals. There will be sterile needles. They can check their substances for fentanyl or other contaminants. They can dispose of their needles safely. This is really kind of a really good example of harm reduction, right? We know that we're not going to get people to stop using the substances, but here, let me help you do it safely, right? So you're here, we can monitor you to make sure you won't overdose. We can give you a sterile needle to make sure that you don't get, hepatitis or HIV from a dirty needle you might have gotten from someone else. Let's make sure that you're not doing it on the streets. Again, it can be counterintuitive, but this really is a great example of harm reduction, um, using what we know as medical professionals to help people do something safely because we know that right now it's the most helpful thing for them and the best way that we can reduce harm. Some other things that are harm reduction in the context of substance use disorder is syringe programs. So programs that allow people to safely dispose of used needles, obtain clean needles. So one of the big risks in substance use disorder, obviously the substances themselves are dangerous, but for things like heroin or other things that you inject, you need a sterile needle, and you can get HIV or hepatitis from not from previously used needles. So, one way that we can make this drug use safer is to provide people with sterile needles to um, prevent, hold on, I was reading the chat, to prevent getting sick from a needle. So someone asked, are there consequences for using illegal drugs in these settings? No. So that's the whole point. You're not going to go in there and be bombarded by police arresting you for using heroin. The whole point is that like getting arrested for heroin is not going to help someone, with their substance use disorder. But providing them with a safe place to do it is going to prevent them from overdosing or prevent them from getting a disease from a used needle. So these are often like government or the government supervised. So there are no consequences. These are kind of people are invited to use these facilities, which again is really kind of hard to wrap your head around if you've never heard of this. Another thing is fentanyl test strips. So if you live in New York City like I do, there's actually commercials that you'll see, or I don't know if it was a commercial. I saw a video on a TV somewhere. Kind of showed people how to use fentanyl test strips. Essentially, it's like a way to test a pill or a powder or a liquid for fentanyl contamination. You kind of ground some of it up, put a little stick in it, and it tells you if it's contaminated. Because even if you have, like, let's say a pill that's contaminated with like a tiny bit of heroin, it can be really, really dangerous. So the kind of philosophy is, okay, well, we know people are going to use drugs. We don't want them to overdose and die from having a little bit of fentanyl. So we can give them these strips to test their substances for fentanyl. It's very cheap. And then you can order them online, these test strips. And again, you're not going to be penalized. You know, it's all about reducing harm, helping people be more safe because we realize that, people are going to use drugs. And our goal is to help them do it safely. Um, okay. All right. So we're going to be doctors. We care about evidence. Does it work? So, because it's a relatively new, I guess, approach to treatment, there aren't so many studies or randomized controlled trials, which are kind of the best kind of study to study harm reduction, but there are, a lot of things in the works. There's one study that I found that studied all different cities that had safe injection facilities. There was another study I found here that kind of followed people who were on, medication-assisted treatment for their opioid use disorder. And it found that compared to people not receiving medication-assisted treatment, sorry, so let's say someone who was just in a rehab program without getting methadone versus someone who's in a rehab program plus is also getting methadone, opioid overdose deaths decreased by 59% for those receiving methadone and 38% for those receiving buprenorphine. So basically what this is kind of saying is that medication-assisted treatment reduces opioid overdose-related deaths. That's pretty strong evidence for using medication-assisted treatment. Our goal, like I said, is to reduce overdoses. And if we can prove here that using these medications decreases overdoses, then that's kind of a really great piece of evidence to support using the medications for treating it. And then, like I was saying before, there's the systematic review, which is kind of a study where they take a lot of different studies and analyze them and write about them. So one city with a safe injection facility, or SIF, there was a 26% net reduction in opioid overdose-related deaths, tongue twister, in the area surrounding the facility compared to the rest of the city. In the areas surrounding one SIF, there was a reduction in crime, as well as a decrease in needles found in public areas. And individuals using SIFs were less likely to share needles. So there's limited evidence about SIFs. I think there's a lot more studies going on. Also, we talk about them, but there really aren't a lot of these facilities. They're very hard to open because residents in the area don't want to be next to a place where people might be using drugs. Although in reality, if they're not going to be doing it in the facility, they're going to be doing it on the street. So that's kind of an argument for why you should open the facilities, because you'll have people doing it inside as opposed to like on the street and finding dirty needles outside of your apartment. But this is just some evidence showing that safe injection facilities do have positive effects on the communities that they are in. All right, so we talked about the case for harm reduction. And a lot of you right now are thinking, okay, so you're telling people to use drugs, right? You're condoning drug use. You're arguing that the government should support people using drugs, supposed to, encourage people to stop using drugs. So I want to emphasize that proponents of harm reduction, at the end of the day, the goal is, of course, to help patients stop using the drugs, right? To obtain abstinence, to achieve abstinence, or get patients into rehab. But because of a lot of systemic barriers in our system, we understand that's not, it's a goal for the long term. But like I said before, like right now, we have to be realistic about this patient. And if we know that we can't get them into rehab right now, or the patient is absolutely opposed to getting help for their drug use, how can we help them do it more safely right now? So I want to emphasize again, that's like the overall goal still is to stop patients from to treat substance use disorder. But again, so the arguments against it are like, okay, it enables drug use. And it kind of these programs imply that the government and the healthcare system encourage drug use, are accepting drug use, and therefore it might lead to increased drug use in the future. Someone might see a fentanyl script commercial or pass by a safe injection facility and be like, oh, maybe I'll start using drugs now that, I can get fentanyl test strips, or I can have a safe place to do it. I didn't put a slide on this, but there is no evidence showing that places with either fentanyl test strip programs or safe needle programs, or safe injection facilities have any evidence that there was increased drug use or people who hadn't previously used drugs started using drugs. So it's a very logical argument, and I could see why someone would have that question. But in terms of like the facts, there is no evidence that these programs increase drug use or would lead someone who has never used drugs before to start using drugs. But with any sort of controversial treatment or a new philosophy, it's important to understand what the arguments against it are, so that we can better, have better discussions and come up with better evidence to sort of support our philosophy and our argument. So there's other ways to incorporate harm reduction that are not opioid use disorder. So this is a little infographic I found for alcohol use, right? So let's say you have a family member who, or a patient, right? And they've been using alcohol for years. They are on a wait list for rehab, or they're kind of in the pre-contemplation phase of getting help, but you know that they're going to go home and they're going to drink. So you could say as a provider, I'm going to wash my hands of this. I'm not going to tell you what to do. You go home, do what you want, but don't drink. Or you could say, listen, I know you. I've been your doctor for 5 years, and I know you're not going to stop drinking anytime soon. But if you are going to drink, tell someone where you're going. Stay around people you trust. Don't mix alcohol, and make sure you're eating. And this can kind of be applied to someone who has alcohol use disorder. But even like someone who just turned 21, or your friend, and they're going out drinking, and maybe you really hate drinking, maybe you don't. But the underlying theme here is like, no matter what the activity is, there's always safe ways to do it. Or not always, there's ways to be safer when doing it. And that's going to apply in any sort of risky behavior. It can sort of, it can apply in sex education, right? So there are people who say, well, the only way to get teens, to not get STDs or to not have teens get pregnant is to encourage abstinence only education, right? To say like, listen, you're teens, you shouldn't be having sex. And I'm not going to teach you how to safely have sex because I'm not going to condone it. And I don't believe that you should be having sex. So that's kind of, one way to do it. But a more productive way is to say, listen, teenagers are teenagers, they're going to have sex. How can we help them do it safely? So, get out condoms, have strong sex education, where we teach people how to have safer sex to get better outcomes, because at the end of the day, harm reduction requires sort of a realistic attitude about life, about medicine, sort of understanding that things are going to happen, even if we don't want them to happen. And so we have to be realistic about how we can decrease the harm. So there was a 2022 study that found that when there was increased federal funding for sex education, there was a 3% reduction in teen birth rates. That's small. But the point I kind of want to drive home here is that, the best way to encourage, to decrease, STDs and teen pregnancies, to encourage safe sex and teach teens, what condoms are, what birth control is, to help, facilitate safer sex and better outcomes. And that's harm reduction, right? Okay, last slide before we get into questions. So I think that harm reduction is a really good attitude, no matter what field of medicine you go into, whatever job you're working at now before med school, if you're still in school, whether it's, helping your friends drink safely, whether it's something like this, right? So you become an OBGYN, a question I got once is that you're an OBGYN, you work in a hospital, obviously, so you encourage people to come into the hospital to give birth so that they can have a C-section if necessary, so you can give them anything they need in case they need it while they're giving birth. And the patient says, listen, I'm the lowest pregnancy, I don't want an epidural, and I want to give birth at home. So if you're a provider, you could say, well, no, I'm not going to treat you unless you come to the hospital. And that might create some discord in your relationship. It might, make the patient not trust you or feel like you have their best interests in mind. Um, and then they could say they're at home and then they're giving birth and something goes wrong. They start bleeding a lot. The baby's not uh progressing as it should be. And they might be scared to come to the hospital because they're like, the doctor, you know, was really it kind of sowed a bad seed of the relationship and like it kind of can create negative attitudes between you and the patient. But if you say, listen, I'm a doctor, so I think that the best place to give birth is in a hospital, but I understand that you want to give birth at home, so we'll make a plan. If you're with your midwife at home and this happens, we'll come to the hospital. You'll have everything ready to go to the hospital if you need. Kind of a bridge between you and the patient, to reduce harm, of course. In the case that something does go wrong with the birth, so that they can come to the hospital. But essentially, again, it's the same attitude. How can we help you safely do the thing that you want to do? Same with substance use during pregnancy. So I didn't know this, almost out of time. But one of my attendings in my psych rotation had a patient who was 5 months pregnant and she was using, I think, heroin. And I said, well, aren't you going to tell her to stop? And she's like, well, if I tell her to stop, she's not going to come to me anymore. She's not going to want to see me. And who knows what's going to happen? She might not come to the hospital when she has to give birth. She might overdose. But if I keep up this relationship, I kind of let her do what she does outside the hospital, whether that's doing heroin. But we keep up this relationship so that she feels comfortable coming to me and talking to me, and she'll come to the hospital if she's sick or if she needs to give birth. That's arguably, might have a better outcome for the baby. It'll be born in a hospital. It can be easily treated if it is born with neonatal abstinence syndrome, which is, what happens if a baby comes out with opioid dependence. But it's really eye-opening for me to sort of hear this provider have a really kind of interesting approach, because her priority was making sure the patient was safe, and the fetus was safe, even if that meant, the patient might be using substances outside the office. Same with psych medications. So there's limited evidence as to whether SSRIs can have, that's like antidepressants like Lexapro or Zoloft or Prozac, have negative outcomes on pregnancy and birth. But let's say you have a patient who's really, really depressed and she gets pregnant. And you know that if you take her off of her Lexapro, she might very well hurt herself or be so depressed that she won't come to her prenatal visits, or worse, in a horrible scenario, commit suicide. So it's safer in that case, even though we don't really know what the effects of Lexapro are. It's better to have her on her antidepressant, have her depression under control so that she and the baby are safe, as opposed to stopping this medication because it might be harmful. So I think the takeaway here is that harm reduction, these are kind of some OBGYN examples, but it can really be used in any specialty. I think it's something that can be helpful even if you're not a doctor. It's something that I really encourage you guys to think about, and figure out how you can incorporate into your life, whether it's as a doctor, as a friend, as a family member, as a pre-med.